All right, good morning. I'm presuming, Janelle, that they can see my screen at this point and hear me?
Yes.
Excellent. Okay. Well, thank you so much for having me here today. I really appreciate it. I understand that there's a little bit of disappointment because it's not Nikki, and everyone's accustomed to having Nikki's presentation and is going through the grief process. She has not yet officially retired. She's going to be retired really, and I mean, she has an app on her phone that tells you exact number of hours and minutes and days, but really it's about 4 weeks from now. So it's coming pretty quickly. So I'm glad that she and I have had a little bit of opportunity to overlap prior to her departure. I appreciate Janelle's brief description of my background. One of the things that she didn't mention was that prior to coming to work for CARF, I was also a surveyor for CARF and was a surveyor for about 17 years. So I'm familiar with the application of the standards. I've always been familiar with the process of how the standards are developed for a number of years, and worked in CARF accredited organizations since 1990. So hopefully that will give you some comfort in knowing that I'm somebody that's been around CARF for a number of years, and hopefully will provide at least a modicum of professional ability after her footsteps. I mean, people say that that she leaves awful big footsteps to step into. So with that, I'll go ahead and get started. I'm imagining that everybody is familiar with CARF, and the sort of the official title of the company on legal documents is Commission on Accreditation of Rehabilitation Facilities. Even though we don't use that name anymore, we just go by CARF International, but that is the official title of the company, and our mission hopefully aligns very well with yours, and that is that our mission is to promote the quality and value and optimal outcomes of services through a consultative accreditation process that centers on enhancing the lives of the person served. CARF believes that really the moral owners of the accreditation process are the people that we serve, and so all of our standards are designed to enhance the lives and ensure quality for them. So what we're going to be talking about in this webinar today are really what are the changes that we made in the standards manual from the 2012 to the 2013 manual. So we will go over each of the changes that was implemented, and we're going to talk in a little bit more depth of the particular standards for health homes and integrated behavioral health / primary care. And I'm going to touch on the eating disorders program, which is a new program area that people may be able to apply for accreditation under. So, as you are familiar with the standards manual, the first section is entitled Aspire to Excellence. These are effectively the business practice standards that are common to all of the different accreditation areas that CARF services. So it doesn't matter whether you are in behavioral health, whether you'd be in employment and community services, medical rehab, aging services. All of the Aspire to Excellence standards in Section 1 are the same in each and every one of those standards manuals. Our philosophy around that is, good business is good business. Now, certainly there are some things. I've done an awful lot of work over the years with folks that I've had in organizations that I've worked at where we've had to do have contracting arrangements or some other business with somebody who's not in behavioral health, and when they learn about things in behavioral health, they would say, your business is kind of funny. Certainly there are some things that are unique to our business in behavioral health, but many of the things that are unique are sort of moved into the Section 2, which are the general program standards, and Section 1 is just predominantly the typical business practices. So I'm not going to go into the areas of leadership, governance, strategic plan, input from the person served, legal requirements, finance, technology, or accessibility. And the reason is because there were no new or revised standards at all in any of those sections from 2012 to 2013. A couple of them have had some tweaks in prior years, but they're not due for any particular change this year or next year, and we'll see what happens as we go through the evaluation process of our standards this year. So the first area where we actually had a change was in G in risk management, and that is that the program implements written procedures regarding communications that address media relations and social media. Essentially, we are looking for some sort of a written procedure that describes the relationship that your organization has with social media. It may include some of your social media activities as an organization, but also it's becoming more and more important for organizations to think about how they talk with their staff and encourage staff to manage their own social media behavior and activity. There have been a number of implications that that have come up with, Facebook and Twitter and Google Plus over the last several years. I'm sure many of you have experienced similar concerns about what kind of information is going out. I think there are. I was doing a regional training in Orlando a couple of weeks ago, and I know one person, was talking about in their organization, a lot of their social media policy had to do with, blocking access to it. That because you couldn't on a company computer, you were unable to access Facebook or Twitter or something like that. That was the way that they were managing it. I would suggest that that's probably not. Really the type of procedure that we're exactly looking for. We're looking for more about the behavior and the organization's philosophy towards it. But it is something to talk about. I made the suggestion when I was the Chief Operating Officer at DeKalb CSB in Atlanta a few years ago. We had a focus group. We got a number of staff, and I really selected a lot of our younger employees, not so much our management staff, who all were similar in age and background, but really wanted to get some input from the line staff, the younger staff who were more facile with social media, to kind of figure out what were the things that we needed to pay attention to and kind of learn some of their attitudes, so that we were able to write a social media policy that hopefully was balanced and not creating rules and regulations that we were going to be unable to ultimately enforce, but that did provide some information to staff about things that they ought to think about, particularly around boundaries and things of that nature. So we're going to be looking for that inclusion in your written procedures around your communications. In the area of health and safety, we made a couple of really just minor wording changes in standard number 4, that personnel received documented competency-based training. There had always been the personnel received the training, and this was just simply moved, and the word documented was added because there were people who, or some organizations were, saying that they had in fact provided the required trainings in health and safety, but they didn't have good, clear documentation about that, and so we wanted to make sure that it was not something that you could infer that just delivering it without having documentation of that training to meet the standard. We included the word documented now. In the evacuation routes, we had a standard that read evacuation routes, signage that are accessible, understandable to the person served, etc. We removed the word signage. Now, we're still going to suggest that there be signage, particularly in larger facilities where there may be multiple routes in and out. If there are some small little, single, office outpatient facilities where, the evacuation route is very obvious, that's the reason why the word signage was removed, because there was some input from organizations that said, why would we have to have a sign when it's, blatantly obvious that this is the only way in or out of this particular location. So ultimately there was agreement with that, and the word signage was removed. Continuing on in health and safety, there were some new additions made to the standard around the unannounced test of all emergency procedures. There has been for many, many years the requirement that each and every one of the emergency procedures that the organization has that are reasonable in an area. So for instance, when you have emergency procedures for bomb threats, fire, tornadoes, etc., each one of those different procedures are to be tested each year. Well, there's a new set of standards around this cluster C that says that the procedures are analyzed for performance that addresses the areas needing improvement, actions to be taken, results of performance improvement plans, and education and training of personnel. The reason is that although we had what you would see sometimes in surveys was that organizations would document that they performed their tests. They might have had problems in the evacuation or something, and then because there wasn't somebody in a leadership role in an organization that was doing the analysis of all of these evacuations, there were opportunities for performance improvement that were being missed, and in some cases, and I know personally I saw this in a couple of different surveys that I had performed, where you would see a problem that was documented, and that problem continued to be present in evacuation after evacuation. So there were new standards added to ensure that the organization does that analysis, that it identifies what activities could be taken to improve the performance, and then there is training of people to make sure to implement whatever that action was determined that would be helpful. Number 8, there was a set of standards around critical incidents, that there was, the types of critical incidents there was a procedure for, the types, who was to be notified, et cetera, et cetera. We simply added one element in that policy to include the documentation requirements. Really what we're talking about here is that there is a description of what those documentation requirements are. So it might say things like, the incident report is to be completed on this particular form and is to be turned in to the supervisor, within X number of hours of the completion of the form, or within so many hours of the incident, or something along those lines. It's not that we have always expected and seen where there was documentation, but really what we're looking for in the procedure here is what are the requirements of that particular of the documentation for the critical incidents. Next is human resources, and there is really a clarification in 2A, and this is around primary source verification. A few years ago, CARF established standards that required that every organization, particularly when you have licensed folks, or there are some requirements around degrees, licensure, etc., that simply obtaining a copy of a diploma or taking a copy and photocopying a copy of a person's license and putting that in their personnel file was not adequate, because certainly it would be possible for somebody to have a document that is not real, I guess I'll say. I wanted to say counterfeit, but perhaps that's not it. Maybe that's not generous. And so we said that you have to do primary source verification, which meant that you could go perhaps on the state's licensure website to be able to ensure that that person was licensed, that you got a copy of transcripts if it was a degree that was required directly from the college or the university, not just simply, again, taking a copy of a diploma. So people were asking the question about, does this apply to high school diplomas as well? Because many entry-level jobs that do require a high school diploma, that is a requirement that is in their job description, is that they must possess a high school diploma or a GED. So there was questions around that have been clarified that said that it is not required that you obtain primary source verification for a high school diploma or a GED, that simply having a copy of that is sufficient. It would only be for the degreed or licensed positions that require that. Again, this number 5 is similar to in health and safety, that there is documented personnel training in number 5. Again, there were organizations providing the training. There wasn't necessarily any disbelief that the organization wasn't, in fact, providing the required training for personnel, but it was not clearly documented, and so now we've simply put in the word that clarifies that training must be documented and ready to view for surveyors. The next item is that the organization implements personnel policies that address, at a minimum, employee relations, including disciplinary action and termination. That's not really new. The disciplinary action and termination portions of the personnel policies was originally in standard number 6. It's now moved into 8 because there's been some other things that were added, and that was what you see here in number 2, which is also that the personnel policies address employee selection, including promotions and job postings. So there must be some sort of written procedure that, or written policy, pardon me, that identifies what the promotion rules and guidelines are in an organization, and what your job posting requirements are going to be in your organization. Okay. The next area where there were some changes is in the rights of the person served, and there is a change to number 3, that the program or service demonstrates knowledge of the decision-making authority of the person served. It used to read knowledge of the legal status of the person served, and a lot of people were interpreting that to meaning things like were they knowledge if they were on probation or some sort of corrections involved situation, or sometimes if they were and we heard some feedback about if they were an undocumented or legal alien, or a person with legal status in the U.S. That really isn't what we meant, so we clarified that to read the decision-making authority. And what we're trying to get at is that the program or service has knowledge of the individual's capacity for decision-making. So maybe based on the individual's age, they may or may not have authority to make certain treatment decisions. It's important that the program or service demonstrate knowledge about that. What is the age in which a person can, for instance, check themselves in or admit themselves for services versus without having parental signature or permission, and then also certainly if a person it has been ruled as not being competent to make their own decisions in their own best interest, the organization should know when persons have had their individual legal decision-making authority transferred to a guardian, and you would want to know who that person is and who the representative would be that would have the authority to make decisions about the ongoing services and treatment. Next is number 4. There was an addition to the formal complaints process, and that was that each organization documents all of the formal complaints received. How you choose to do that clearly is going to depend on what your organization's volume is, but if you're a large organization where you have multiple sites and you may be getting a number of complaints, you might want to look at having a database or a spreadsheet or something where you are logging those formal complaints and really tracking through the process, ensuring that you're meeting any of your policy requirements in terms of if there's any response that you need to make to the individuals that your organization is serving, if there are activities that are going to be addressed in the organization based on those complaints. You'll just want to have some sort of a process where you are tracking and monitoring that. A lot of times you'll have organizations that have very formal and well thought out procedures for their formal complaints, and then you'll say, well, okay, I'd like to see them, and the organization, so we've never gotten any. It sort of makes you question how well that program is working if no one has ever made a complaint in 3 years that they've not been dissatisfied with any of their services or anything along those lines. So that also gives those of you who are in executive level positions, it gives you an opportunity to sort of review that in an aggregated way to see that too. If what are the complaints, and are there things that you should be doing in order to make some changes to the organization, and also if you're not receiving any, then you may ask the question about, well, how effective is our complaint procedure? Are we really going out and seeking input from the people if no one is providing any complaints at all? As much as we would all like to think that, well, the reason that we're not seeing any complaints is because we have nothing but satisfied customers. It's unlikely with the population that we serve that we're always going to satisfy them 100% of the time, and we do want to find opportunities to get better and improve. And then following on from number 4 is number 5, that on an annual basis that there is a written analysis of those formal complaints. So if you document and track all of these complaints on an annual basis, then at some point on the calendar you'll have a time frame where somebody's going to sit down and say, all right, let's look at, are there any themes, were there any trends that we were seeing in these complaints that we need to look at making changes to our practices? Is there some training that perhaps we need to do around whether it's customer service or transitioning people from one level of care to another, or something that may jump out at you as you look at the particular complaints on an annual basis. Next is around performance measurement and management. There has been a performance measurement and management system and requirements for a number of years, obviously, and there was a written plan that the organization really had to have around how it was going to collect data and analyze that data for the purposes of performance improvement. There were a few elements here, including the mission, programs and services seeking accreditation, objectives of the programs, services seeking accreditation, personnel responsibilities, and performance measurement and management. These were added essentially to provide context for the purpose of this measurement system. So it says, here's what it is that we're doing. Here's as an organization, our mission is to do X. These are the programs that we are seeking accreditation in: outpatient, intensive outpatient, case management, etc. The objectives of these programs or services are is this, to improve the functioning of the person served, et cetera, and then here are the things, eventually, here are the activities that we're going to use, or the data that we're going to gather to evaluate the performance of the system, and then who are the individuals that are responsible for what? For the data collection, for the data analysis, and when are those activities supposed to be engaged. So you would identify if on a quarterly basis there's some sort of reporting or aggregation of that data, you would describe that in this written description of performance measurement and management at this time. Well, my screen has gone blank. All right. Next, in item number 3, the data collected by the organization. There's a couple of little tweaks essentially that was made to this. There predominantly are 2 functions in a behavioral healthcare organization. There's business functions and service delivery functions. So the data collected are used to set objectives, performance indicators, and performance targets, and then written service delivery objectives, performance indicators, and targets. There's another sort of tweak here with that word target, and it used to be that it was that there would be a goal that the organization was setting. That was problematic for some organizations because they weren't sure that this is what they would define as a goal when they were measuring their performance, particularly around some of their business practice functions. So we changed the word from goal to target, and that target should be based on something. It shouldn't. It could be prior benchmark data, but really what we're looking for around the service delivery side in particular is that if you are using some sort of an evidence-based practice, that you have some sort of a target of performance for outcomes, for program completion, something that you can measure yourself against to see whether or not your organization or your programmatic performance is really meeting the level of performance that some other program doing the same sort of service is achieving. Now, the performance measurement and management ties right into the performance improvement. Again, there was a change to the word target from goal. It's exactly the same as it is in the prior section. Okay? So that's really all of the changes that were made in section 1. So Janelle, this might be a good time if there's any questions that need to be answered at this point.
Sure. Great. Thank you, Mike. Okay, we have one question from Stacy on the slide on health and safety and unannounced tests. She asked, how often are the written analysis required for the emergency testing? Is it annually?
Yeah.
Okay.
Yes, it would be an annual analysis. Yeah.
Okay, and then the next question that we have is from Susan on the rights of persons served, number 3, where it says the program service demonstrates knowledge of the decision-making authority of the person served. She was wondering, how might a provider organization demonstrate that?
How might what organization?
How might an organization demonstrate?
Interestingly, that's one of those standards that the way that that's going to typically be applied is a surveyor is going to ask staff a question. So they're going to ask questions like, what's the age that a person in the state of Ohio can access services without parental consent? And so they might ask a couple of different staff that question, for instance, and if they get a consistent answer, then they're going to presume that that staff do know this. They're going to ask questions about, if a person has a legal guardian, how do you interact with that legal guardian? This isn't necessarily something that you're going to look at in a written policy. It's going to be applied really through the interaction with staff. So my suggestion would be that might be something that you put on your list as an organization of things that you want to ensure that staff are trained on, so that when they're interacting with those surveyors, that they do A, know those local rules, and B, that there's a consistent message that's being delivered.
Okay, great. And those are the only two questions that we had on that section.
Great. All right. So moving on to Section 2. So Section 2 go through the new and revised standards. In the general program standards, again, these are the standards that apply to all organizations for accreditation, regardless of the particular types of programs. For those of you who have a standards manual handy, on page 96, there's something that's called the applicability table. What this is it identifies that there are some program areas for things like assessment and referral, for instance. If your organization has an assessment and referral program that does not provide treatment services, it merely is doing those assessment and sending people out to programs based on the needs that are presented in the assessment, there are certain things that would not be applicable because you're not providing that ongoing downstream treatment. So that modifications table the applicability table on page 96 identifies what standards do not apply to what program areas under what conditions. There were no changes that were made to that particular table in the 2013 manual, but always remember that table does exist, and that there may be some things that you would be exempt from based on the type of service that you have. Again, if you've got a prevention service or a assessment and referral service, there would be some things that would not apply because you don't have, in a prevention program, for instance, you don't have identified clients or persons served. The first section in Section 2 is Program, Services, and Structure. In A10 here, there is a new standard that reads, when the program is identified as a treatment program, it identifies the treatment modalities and the credentials of staff qualified to provide treatment in that program. So really what we're looking for here is in that written description, which you've always had to have. I mean, if you have a program, you have to have a description of that program that for every area that you were seeking accreditation. We're looking really for you to add something to that written description that talks about the types, the treatment modalities, which, if you, offer trauma-focused CBT or motivational interviewing or something along those lines, that you would define the types of treatment modalities that you implement in this particular program, and then lined up against that would be what credentials of the staff would be required in order to be able to provide the specific treatment modalities that you offer. And of course, then an extension of that would be that we would be looking to ensure that the people that you define as being able to provide that type of service are actually providing it, and that they are maintaining it. If there's particular training requirements on a regular basis, we're going to be looking to ensure that you are conforming to your own standards that you've defined in this particular program description. In number 24, which really has to do with handling of either licit or illicit drugs coming in, and how you're going to dispose of any of those things. The intent and examples, so not the standards themselves, but just simply added to the intent and examples. There was some expansion to include tobacco products, and not just smoking. There's always been kind of some things around smoking policies in particular programs. Now we're talking about more than just simply smoking. We're talking about chewing tobacco, green cigarettes, etc. In item 14, which simply identifies the different elements that needed to be in the assessment process, we added living situation, a description of the living situation that the individual is living in or was living in prior to coming to treatment, and that be included on your assessment document. Then we skip all the way down to the medication use section. Every organization has to have a policy on medication use and how it manages medications. The policy used to read that the organization has a policy that identifies blah, 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 and then the process for persons served to obtain medications and everything. If you describe, dispense, or administer medications. We added if you control medication. So you certainly might not prescribe, dispense, or administer medications, which would appear as though it wasn't applicable before, when in a residential program, for instance, where you might control their medicine and it's self-administered. A person goes to a lockbox, they open it up, they take out their medicine. That wouldn't fall under prescribing, dispensing, or administering medication. So folks thought that they were excluded from the policy before, and now we've added medication control simply to ensure that that those programs also have a policy that identifies their process, just like those other programs would. Okay, jumping down to nonviolent practices, there really weren't any standards changes in the nonviolent practices, which used to be called seclusion and restraint. But in 2E, the example, there was an additional reference made to a new practice to prevent crisis and seclusion and restraint called emotional CPR, eCPR. So the information around the particular link to that organization's website and a little bit of definition of it there is identified in the example in nonviolent practices. Okay, so again, we've come to the end of Section 2. Are there any questions about any of the changes in Section 2 at all?
Yes. The first question that we have was back on the slide on program and service structure. And Penny was asking that you would again, and she realized that you did, define again sort of the treatment modalities in that program and service structure. Again, define it? Yes.
Yeah. Really what we're talking about is the particular type of clinical intervention that is being used. If there is a particular sort of psychological philosophy or a particular intervention, as I said, such as motivational interviewing, cognitive behavioral therapy, EMDR, if you're using any of those types of interventions as a treatment modality, then you would define what that is that you implement in this particular program that should be matched up against the population that you're serving that would, based on evidence, achieve the types of improved functioning and goals that you would expect are a good match for that particular intervention, and then what are the qualifications or requirements that any staff person would need to achieve in order to be able to utilize that particular modality. Any others, Janelle? Are you there? Okay. Well, not hearing Janelle, I will just go ahead and continue on with section 3 at this point. So in section 3, we have a new field category. Now, what the field categories are is essentially a description of the particular population that you serve and how you believe you're organized. So, for instance, other field categories that organizations would apply for would be alcohol and other drugs or addictions, mental health, integrated mental health and substance abuse, and so on. So really what this means is that you're going to identify the particular programs that you are seeking accreditation under. And that could be, again, outpatient, case management, intensive outpatient, residential treatment, detox, or whatever it might be. And then you also define what's the particular field category. So if it was, integrated mental health and substance abuse, you would identify the field category and then the particular programs. Well, now, because we added the health homes and the integrated behavioral health primary care programs, those existing field categories didn't match up with that very well. If you were looking for, if you were a health home and then your population that you were serving was just mental health, for instance, that doesn't describe the additional medical services, screening, care coordination, all of those activities that your organization would be participating in. So we created a new field category called comprehensive care, and it's going to essentially be for the mental health, addictions, or developmental disabilities, and the coordination with the healthcare needs of the particular person. And how those are implemented are slightly different whether you're a health home or what we call an integrated behavioral health primary care program. And when we get into those particular areas, we will describe kind of the differences between those two different program areas. Really, one of the few changes that there was in the 2013 manual is in the community housing section. And the first change was simply to the program description. Originally in the program description, it talked about a time frame where the transitional housing was I think it was defined as being from 6 to 9 months. Well, you know, nowadays there's an awful lot of permanent supported housing that people are living in through different HUD kinds of projects and things like that. So really the change was that they completely removed the time frame. There is no time frame, and it includes apartments or homes. Originally the description was for homes, and I mean, I don't know that people were arguing too much that an apartment wasn't a home, but just for the sake of clarity, for surveyors and for the organizations alike, we included the words apartment and homes to make sure that no one was getting confused about apartment style programs. Number 9, there was some additional standards added, and that is that if there is some congregate housing arrangement, that there are sleeping areas identified based on age, gender, or developmental need. Really the purpose of this is to ensure that there is some privacy that is being afforded to the person served, and that there is space for people to express themselves and have their individual, you know, engage in their own individual interests in their homes. So, so those standards were added for that purpose. Okay. Now the next slide is health homes, and let's talk about, from CARF's point of view, what the health home is. Really, the health home focuses on the whole person and provides integrated health care coordination that includes primary care and behavioral health care. It's capable of assessing the various medical and behavioral needs of the person served, and really provides a whole host of particular services such as screening, evaluation, crisis intervention, medication management, psychosocial treatment and rehabilitation, care management, community integration, and is designed to assist the individuals in addressing their behavioral health needs, and really is ensuring access to and coordination of care across their primary care and their specialty healthcare and behavioral healthcare services, and monitors the critical health indicators that are the big health drivers for the people that we serve in our population. Also, the health home is going to be responsible for collecting, aggregating, and analyzing the individual healthcare data across the population of the person served by the health home, and uses that data to manage and improve the health outcomes of the population being served. Not really looking at this on an individual basis, but is looking at population health and sort of from a public health perspective, trying to ensure that that the right things are being done in the aggregate that's moving the health indicators of that population in a positive trend. Okay? So the first standard is very similar to the same standard that would be in each of the program areas, and that there is the written program description, that clearly defines the population that's being served, how primary care and other services are going to be provided, accessed, and coordinated, what the procedures are going to be around the referral to external services, and the process for the care coordination, both from an internal within the team as well as with the external service providers. This really is not significantly different than any of the other program areas. There's just a little bit more detail, obviously, around the service coordination than there would be in some of the other program areas that you would apply for accreditation. So the second standard is that the program is organized and delivered in a manner that ensures an integrated team approach and inclusion of complementary disciplines needed by the person served. What we're talking about here is, in terms of these complementary disciplines, it really is dependent on the population that's being served. It could be that the population includes other medical professionals, dental professionals, nutritionists, but if you're serving a large children's population, it might be educational specialists or school psychologists that might be included in the complementary disciplines that are a part of the integrated team approach. So really it's going to be customized. You're going to define what that team is and who it's made up of, depending upon the particular population that you're serving in your organization. So next talks about, when primary care or other healthcare services are provided directly by the health home. Support for these services included the co-location with the appropriate physical space, the written procedures regarding how the primary care or medical services are going to be accessed, how information is going to be shared between the primary care and the specialty mental health services sort of sides of this healthcare or health home, and how the care is going to be coordinated. And also ensuring that there is cross-training for the most common chronic medical and behavioral illnesses prevalent in the population served. So really this is going to show that you are having training for both the physical health side on the common psychiatric illnesses that the majority of your population have, and then the mental health side is going to be trained on some of the common illnesses and symptoms and health outcomes for the illnesses that our population typically have, such as diabetes, hypertension, COPD, emphysema, all of these types of illnesses that we commonly see in a chronically mentally ill population. Just like in all of the other program areas, the program identifies the hours of services and the hours when the healthcare services are available, and ensures the availability of the following. And it lists, psychologist, primary care provider, and then, when needed, professionals legally authorized to prescribe. So depending upon the particular state laws, the other prescribers that might be a part of that health home and when they would be available, when the care coordinator is available, and then our sort of generic definition, other qualified behavioral health professionals based on the needs of the person served. So whatever those qualified behavioral health professional definitions are in your state and your program, you would define who they are and when they're available to provide services. We have two standards here, the 5 and 6, when neither a psychiatrist nor a primary care physician is a member of the health home team, a psychiatrist or primary care physician is available for consultation and or program oversight during the hours of operation. And then when they're not provided directly by the health home, off-site treating psychiatrists or primary care providers are offered care coordination and disease management supports just as if they were in the health home to facilitate and enhance treatment for the person served in the health homes. It may seem a little odd that you would have a health home where perhaps you wouldn't have a psychiatrist or a primary care physician as a part of the health home team. Really that is the preference, but in the process that CARF goes through in the International Standards Advisory Committee and the International Advisory Committee that CARF has, you can foresee that there may be some circumstances where you might have a mid-level, for instance, a nurse practitioner or a PA that is a part of that team that is available and accessible a number of hours during the day, and that the primary care physician or psychiatrist, being in a rural location, might not be directly on site, might be remotely accessible via telemedicine or something along those lines. This wouldn't exclude that organization from being able to become accredited as a health home, but essentially you're defining how those working relationships are going to be, and ensuring that the care management continues to go outside of the organization if that person is receiving services outside of the health home itself. Number 7 here is a fairly long standard with a lot of elements, but I'm going to draw your attention just to a couple of the keys here, and that is these are the primary services that we see being delivered by a health home exclusively, and those are going to contrast some with the integrated behavioral health primary care program area. First is that it reads the health home team ensures that the following services are provided: health promotion, including education. So that's a primary activity that a health home is expected to perform. Care management services, including the outreach and engagement, comprehensive care management and care coordination. That is going to be scaled up or scaled back depending upon the particular needs that an individual has. If they have a great deal of health acuity, then we would anticipate there's a great deal of care coordination that's going on across the system, and less for people who don't have acute illnesses either on the psychiatric side or the physical health side. Transitional care, that we're going to be looking to ensure that that health home provides good transition planning and care between whether it's medical stays, ensuring that information is flowing around the treatment history and medications from the physical health side to the mental health side, and back and forth. And I know that I'm calling it sides, and we're thinking about health homes, and certainly all of our goal is the integrated team. But it's just like in any team-based work, there are particular activities that are performed by individuals that are licensed or trained to do that. If you have an outpatient location, for instance, in mental health, you might have a primary therapist and a case manager that's assigned. Both of them perform their unique activities in interacting with the person served, based on their particular skill, and there needs to be some mechanism of coordinating between the case manager and that primary therapist. Sometimes, my experience, professionally, is that sometimes we haven't been that good at ensuring that there's good communication between, those two team members. Now we're further complicating that by adding additional medical service providers, and so we're wanting to make sure that as a key activity that a health home performs, that we are in fact ensuring that there is good care coordination and communication between each and every one of those team members. Additional services provided by the health home are the individual and family support services, including the education regarding concerns applicable to the person served, education and training in the self-management of the chronic diseases that our person served often have, and then, when possible and allowed, interactions with the family members to identify the impacts of the disease of the person served to the family, and to offer education or training to the family in response to those identified concerns. In our International Standards Advisory Committee in the development of the health home standards, the consumer family members were really insisting that that these particular standards be there. Oftentimes, we might focus a lot of education on the person served, but the family doesn't necessarily get all of that information about their behavior and how, or that disease, and how either one of those things might impact the family, and then what's the family supposed to do, or how are they supposed to react in a acute crisis situation. So those standards were put in really at the request of those family members. And then referral needed to community and social supports. Okay. We've been talking about that care coordination, and again, there's a little bit of what looks like redundancy, but this is identifying, that the care coordination is going to happen, and that the sharing of information as a part of that care coordination activities ensures that treatment history is shared, the needs are shared, the medications are shared, the identified goals of the individual being served, and then any identified treatment gaps, as well as the information sharing around the primary care, behavioral health services, hospital-based services if appropriate or if applicable, and then the specialty care and others when applicable. If there is a transition between inpatient and outpatient levels of care, the care coordinators are to be involved in that transition, ensuring the smoothest possible transition from one level of care to another, and that communication that is happening between all of these healthcare providers is happening in accordance with HIPAA and or other applicable laws and authorizations. The health home enhances access through the following: flexible scheduling, capacity for same or next day visits, and excluding, of course, weekends or holidays if that health home is not open on the weekends or holidays. Staff response to phone calls on the day that they are received, and then after hours access through coverage that shares necessary data, provides a contact summary to the health home, and includes a warm line or recovery supports. Next is sort of a generic staffing standard around essentially that there is adequate staffing providing access to a variety of disciplines that would be appropriate to respond to the needs of the person served, coverage that allows for warm handoffs between different levels of providers, and has enough staff that is backup for unplanned or planned absences. And again, just like most of our other programs and our philosophy at CARF as sort of a person-centered philosophy, the program assesses its performance and responds to the needs of the majority of the targeted population by providing services in locations that are accessible to meet the needs of the individuals being served by the organization, and at times that are most convenient to the needs of the person served. So this is a little bit just about halfway through the health home standards. So before we go on, if there are any questions that I can answer, this might be a good time to do that.
Okay, great. Thanks, Mike. And I apologize earlier, I lost my audio connection. So first I want to go back to the question I was trying to ask. This is the previous section, is what are green cigarettes? And that was a reference to slide back.
Yeah, green cigarettes are you may have seen them. It's I see them sometimes. They're stunning because you'll be indoors someplace where you know that smoking is not authorized, but somebody's smoking. It's those, like those electronic cigarettes, or that's not really a tobacco. It's like some sort of steam or something along those lines. So that's what they're referring to in these green cigarettes.
Okay. And then one question on the community housing section from Susan. Separate sleeping areas in Section D, where it talks about in congregate housing provisions are made to address the need for D separate sleeping areas based upon, and asked what does separate area mean?
Well, they're talking about segregated, based on age or gender. So it would be in a room, So if you you wouldn't, if you have, let's say that you have a group home or a type of situation for transitional living where, and when I say by group home, I mean you got a house and you may have a 3-bedroom home and you might have 5 people living in that, where you've got some people sharing a room. You would not have people sharing a room that were mixed gender or adults and children. So they can live in the same home, but they need to have segregated living space based on age or gender.
Okay. The next question from Colin on standard number 3 is co-location required with primary care?
Mm-hmm. Is it required?
That was the question.
Well, I mean, in the health home standard, what I'm stammering here because I'm trying to figure out how to say this the right way. We would have the expectation that they are co-located, but it doesn't necessarily need to be in the same building. For instance, it could be on a campus. There might be 2 buildings right next door to each other, and one has the primary care and the other has the specialty behavioral health services. That would not exclude you from being an appropriate health home, but it shouldn't be across town. I mean, if you're not providing that service where the team is able to interact, then it probably isn't a health home.
Okay. The next question is, what is a warm line? Person likes the term, but they don't want to assume they understand what it means.
Yeah, the warm line is some sort of a call center, or some sort of after-hours service where people can get information if they have particular questions about their illness, if they are maybe trying to determine if they are needing to see their physician again, where they can ask some questions. Now that doesn't have to be something that is provided directly by the organization. It could be done via referral if there are some other resources that already exist in the community.
Okay, and then the last question that I have at this point in this section from Ken, sorry, one more came in and it just took that off my screen. Does enhanced access or after-hours access mean 24/7 access or coverage?
Does it mean that there has to be 24-hour access?
Yes.
Yeah, no. And really what we mean by after hours, it would be that outside of what we might consider the typical, 8 to 5 workday, that there is some after-hours access to services to meet the needs of the person served. And I mean, some of that you're going to be determining as you're establishing what those needs are. You might do that through some sort of surveying or something along those lines that said that, if you were open until 7 o'clock or 6:30 even, that meets the needs of 85% of your population. That would be fine. But you're going to need to define what your population is requesting from you, and that your goal is to try to meet the needs for those after-hours services. You could also potentially have an arrangement with some other entity that may provide by contract some after-hours services to you, one way or the other. But we don't have any expectation that a health home would be open 24 hours a day.
Okay, and we've got a follow-up question to the previous one about co-location, and it references ODMH requirements, where it talks about that ODMH says that they can have a physician on the health home team that reviews cases, but doesn't have to practice, doesn't have to have their practice at the same location, as long as there's a care. And then the person goes on to note that clients have the right to choose other primary care physicians, and they can't be forced to see a primary care physician as part of that's on the health home team or with the organization that the provider may have an agreement with. There's still a requirement for care coordination. But so their concern is
but see, it's the same. And Janelle, you might look at it differently, but I look at it as the same as any other accredited program. If you're operating a typical sort of community mental health center, and you have all the different types of programs that a typical community mental health center has, you would have clients or consumers or persons served that would be in some programs and not all programs. The health home would be for those people who don't have a primary care physician. If an individual that you're providing, say, outpatient services to is engaged in receiving primary care through, whatever mechanism, they have health insurance and through their employer, and they have a primary care physician that they're seeing as a part of their health plan, and they are not essentially enrolled or admitted to your health home, then no, you wouldn't have a responsibility for care coordination for that individual, because you're not providing all of those services. The care coordination is for those people who you would have what I would call, in quotation marks, that you're admitting to your health home program. And let me, like I said, so there is a little bit of a difference there on that, like I said, because part of our health home service and the setup in Ohio, is trying to still get into the people who qualify and need, and still respect the right of consumers. But what I think makes sense at this point is, why don't, Mike, if you and I and Afed, if we talk about this a little bit offline afterwards, and then we can send out some information, because we have everybody's email addresses if you're on this, and we can send it out in sort of a clarifying response on that, because it's also 2:55. And I know we got started maybe 5 minutes late because I was trying to get my audio established at the beginning, and so I want to have make sure we have time to get through the standards. Is that fair? Oh yeah, sure, and that's fine. And I mean, one of the things is that it's always sort of the funny thing with us as an accrediting body or anyone else, and that is that we do build our standards that are sort of generic from a state perspective, it is always our expectation that you follow whatever the local rules and requirements are from either your state laws, funding requirements, or whatever, regardless of whether that would be a standard or not a standard from an accreditation perspective. So, it is important that folks understand and know what your local rules and regulations are, even though it might not be a standard that we would be looking for.
Right. So
okay.
Let's get back to it, because I think, I think it's just an issue of how the people are designing their health homes now. But we will get back to you with an answer. I'll say within the week, just based upon even my availability and schedule. Hopefully before that, but we have to have time to up.
Yep. Sounds good.
So okay, and that's the last question that we have so far.
Okay, so we'll move along. Continuing on here in the Health Home Standards, the program offers education services. That's understandable. Includes family members. Includes information around health promotion, wellness, resilience and recovery, the interaction between mental health and physical health. Prevention and intervention services around smoking cessation, substance abuse, increased physical activity, and so on. You've got the slides. I'm not going to read each one of those to you, but basically you're going to want to ensure that you have a robust health education program that includes all of these things. It doesn't necessarily mean that every single person in that health home has to get all of these services. It's going to be based on the individual needs of the person. Obviously, if a person doesn't smoke, they don't need smoking cessation, or you don't want to even offer them smoking cessation classes simply because we offer it to everybody. But you need to have a robust enough program that you can offer services to people based on the things that you're seeing with that individual. Next is policies around initial consent. That includes information about how information is going to be internally shared amongst the providers in the health home, how it will be shared with any collaborating agencies, and it overtly says that the person has the ability to decline health home services if they so desire, and then what procedures will be followed by the organization if the health home services are declined. So your consent's going to need to articulate all of those things. Number 14 talks about when screening procedures that there are written screening procedures that clearly identify when additional information will be sought in response to presenting conditions, what tests and external assessments are going to be performed. And the reason for this is to essentially prevent the possibility of attributing medical conditions that might be present to a psychiatric issue. Our folks have historically had that as part of the stigma issue, where sometimes people have health issues that are being attributed to psychiatric issues even before tests are being performed to look at any of those possibilities, simply because their behavior in that primary care office might be bizarre, or in a way that is making the healthcare practitioners a little uncomfortable. Health assessments are to be performed that include suicide risk, depression, all of the things you see on the screen here, most of which would routinely be assessed as part of a standard health screening. There are a couple of examples of that. On the physical health side, in a standard health assessment, a lot of times health practitioners, they don't screen for suicide risk, depression, or substance use, or chronic pain typically the other things are going to be screened. So whether the health practitioner performs that screening or whether the specialty mental health staff perform that screening, it can all be combined. It doesn't have to be done at once by one person, but you want to ensure that the health screening does in fact include each of those elements. It's conducted or reviewed by a nurse, nurse practitioner, or other equivalent medical personnel, completed for all the persons enrolled in the health home, as well as being updated on an annual basis. So at the time of the annual assessment that you would do as a part of your ongoing admission to specialty mental health programs, you're going to update their health status and health assessment at that time. All of the assessments are going to result in an individualized integrated plan, the same as it does on the specialty mental health side, but that includes their medical needs and their behavioral health needs into a integrated plan. So everyone should be working off of the same individualized plan that is the result of all of the health and behavioral health assessments. And of course it should include the person served and other stakeholders so that they are able to direct what services and the intensity of the services that they want, and is reviewed by the people necessary to carry out the plan. There's to be another set of written procedures that define follow-through processes and in response to the initial assessment that talks about when reassessments would be appropriate, again, based on the individualized needs. If a person needs to be seen in, 2 weeks or 3 months, that needs to be defined in how those processes are going to be implemented. Documenting the linkage, identification of staff members that are being responsible for care coordination in the health home, and identification of the responsibilities of the care coordination staff, including the self-management, determining availability of needed supports, etc. The written procedures guide ongoing communication. Essentially, this is how you're going to share information. There needs to be that written procedure that is consistent with HIPAA or local state guidance around privacy and confidentiality. And then something that's unique to health homes, and this has to do with, at the beginning when I was describing the health home, I was saying how there is information that is used and analyzed from a population basis to ensure that the interventions on that population are achieving the health outcomes that is being sought by that health home. And so the program is going to use either patient registries or electronic health records for the purposes of collecting and analyzing data, looking at the incidence of disease, the particular outcomes that are being achieved by the population by disease, etc. You're going to define that, and you can define that based on, again, the population that you're serving, but you're going to need to define that in advance and sort of think through what population metrics are you going to be collecting and analyzing on a routine basis. You're also going to be looking at, we would anticipate that you would be e-prescribing and that you would be looking at the prescribing practices of your staff and giving feedback to the staff. If there is some particularly dangerous practices that are being employed by some of the physicians on staff, if there's some dangerous polypharmacy that is present, or if people are prescribing medications at higher than FDA maximum dosages, etc. So that would be an activity that your medical director or chief medical officer would be engaging in that health home. And then, of course, tied into the performance measurement activities in Section 1. You're going to have, what are the measures that you're going to be looking at? Are you going to have process measures, meaning, assessments for substance abuse are, being done 98% of the time for all people coming into the health home. That's an example of a process measure, and then you're going to be checking to ensure that you are hitting that process measure. And then outcome measures both for medical status and behavioral status. So you're going to want to look at that again, both on an individual and an aggregate population-based way, as well as what are the real-life functional outcomes for the person served and the perception of care, or essentially that's just a different way of saying what's the satisfaction level of the persons that are being served by the health home. Okay, so that is it for health homes. Next we have the integrated behavioral health primary care, and these programs are also looking at treating the behavioral health concerns and the medical or physical concerns that an individual has in an integrated manner. Now, the big difference between the integrated behavioral health primary care versus the health home is that there may be a variety of different models. You may have a contractual relationship with a third party that are two separate legal entities that may enter into an agreement to staff and operate a single program at a particular location, kind of a co-location kind of scenario, or there could be that they are being provided by the two separate legal entities in their own locations, but that there is some information that's being exchanged and shared and coordinated across both of those entities to ensure that the individual is receiving the highest level of possible care, and that the treatment services are being provided that are monitoring the health outcomes and the health needs that the individual has. So there's a little less responsibility in the integrated behavioral health primary care program area for care coordination and health education than there is in the health homes, but other than that, you're going to see that there's an awful lot of similarity. So there is just like in the health home and in all of the other program areas, there's a written program description that identifies the population served. It identifies what are the integrated services that can be provided internally versus those that are contracted out or through some other arrangement or agreement, and then contrast it again with what are the referral procedures for other services that might be needed by the person served that may be outside of the arrangement that's even between the behavioral health and the primary care organization. I'm sorry. There must be an integration of identified disciplines that's supported by either co-location or physical space arrangements, and then the written procedures for that co-location and coordination, and applicable cross-training similar to the cross-training that you would expect to see in the health home. Number 3 defines that if the co-location is not possible, if the services are being provided in two separate locations, that there is a way to ensure that the information is being shared appropriately and that it's being coordinated across those disciplines. There's not anything here that talks about, there's a written procedure for or anything else. So essentially the way that standard is going to be applied really is going to be through interaction with staff, and interaction with the clients, asking questions about how that information is being shared. Here again, we have the program describing the hours when the services are available, ensures that one or more of the following medical staff is on site during the hours in which the medical services are offered: physician, PA, or nurse practitioner. Again, very similar to what we already discussed in the health homes. That a psychiatrist or psychologist available for consultation during hours of operation. In the integrated behavioral health primary care, the psychiatrist or psychologist doesn't have to be on site, but has to be available and accessible, whether that's telephonically or via telemedicine. Behavioral health providers are available on site during the hours of integrated service operation. So they're going to be expected. There is the expectation that behavioral health providers are on site during the hours of operation on the primary care as well as the behavioral health, specialty mental health side. There's adequacy of staffing, again the same as in the health home, that assures that the needs of the person served are being met by the different disciplines that would be needed by the person served, and that there is enough backup for planned and unplanned absences. Again, that in a person-centered program, the locations of the services are going to be accessible and are going to be delivered in locations that meet the needs of the person served, as well as at times that meet the needs of the person served. There are some education requirements around wellness, resilience, and recovery, the interaction between mental health and physical health, and the self-management of medical conditions and behavioral health concerns. But you can see by this standard that the education requirements in the integrated area is significantly less than the expectations on the health home side. Policies regarding the initial consent to treatment, again, how information will be shared, and then if the person declines services, what are the procedures that are going to be followed. Screening procedures based on the specific needs of the population and presenting conditions of the person served. So again, you're going to identify what are the screening procedures. If you're going to be using any particular screening instruments, they should be based on the typical population that you see on a day-to-day basis. Written procedures for the intake assessment to determine the initial level of care and the need that the individual has for integrated services, as well as if there would be needs for immediate referral to specific either internal or external providers based on the results of that assessment. The assessment is going to result in an individualized integrated plan similar to what we saw in the health homes that integrate with both the medical needs as well as the behavioral health needs, and the person served is going to be involved in collaborating with the team, and all the staff that are necessary to carry out the plan are involved in the development of that particular plan. Standard 14 in this section, written procedures, define the follow-through. Again, these are almost the same standards that we saw in the health home slides, and so I'm not going to go over those again. Again, written procedures guide the ongoing communication. Again, almost the same standards that we saw in the health home side. That these written procedures are going to be again, driven by HIPAA or local state guidance for privacy and confidentiality. And the last standard and integrated here is the performance measurement includes indicators addressing how service delivery responds to the needs of the person served in an integrated, holistic manner. So you would just simply want to ensure that this element is a part of the performance measurement system back in Section 1. Okay? So I'm just going to keep moving on at this point in order to get through, and then if we have any time, we can respond to questions at the end. There, in intensive outpatient services, there were a couple of minor changes made to those standards, and it was just to identify the number of hours that treatment services are to be provided. So if the intensive outpatient program is servicing an adult population, there must be at least 9 direct contact hours per week of treatment services. And if they are serving children or adolescents, then the intensive outpatient services needs to provide at least 6 direct treatment contact hours per week. That was the only change there. In the partial hospitalization section, there was a change made that reads, when applicable, based on the needs of the person served, a psychiatrist is available 24 hours, 7 days a week. And then there is an initial assessment of the person served was changed from primary assessment of the person served. Not a significant difference, but there was no change in the intent. It's just that the language was changed to reflect what people felt most comfortable with. Residential treatment, very minor, that based on the needs of person served, services are provided by a coordinated treatment team. It used to read provided by a coordinated team. So just treatment now has been added, including the following professionals, and it's the same as was defined before. And then Section 4 are the specific population designations. Typically these are voluntary, depending upon who you're serving. Unless you do serve child and adolescents, you do have to apply the children and adolescents specific population designation. But we did add a specific population designation this year for eating disorders. You need to look at the eating disorders standards. They are we worked in collaboration with the International Eating Disorders Association to develop these particular standards, and they have only been authorized to be used with residential or inpatient programs. So if you are a partial hospitalization program currently that provides eating disorder services, you cannot currently apply the special population designation for eating disorders. Just for your information, we have been in discussions with the International Eating Disorders Association to see if we would be able to bring these to a partial hospitalization program area as well. Their initial response to us was favorable. They think that's probably going to be something that they would support, but they're having to do some review and polling of their association to see first. As soon as we know, and we're hopeful to get that, we would love to be able to make that change for the 2014 manual, but we're just going to have to keep working with them and see how that eventually ends up. Section 5, this would be for the ID or DD types of programs that are providing those services in a behavioral health care organization as a way to not have what we call a blended survey, or a survey that goes out of 2 manuals. So the standards that are in Section 5 are the exact same standards that are in the Employment and Community Services Standards Manual if you were to apply for accreditation under that particular division of CARF. Home and Community Services, Section J, from the 2012 manual was deleted, and there was a new section called Employment Skills and Training that was added. In the program services and structure, there was some change around if behavioral change approaches are used, that positive behavioral interventions are to be being used in conjunction with any restrictive procedures. So if there are any restrictive or rights restrictions that are being employed, that there would also be positive behavioral interventions used in conjunction with them, and that the 13 is complementary to 12, which simply says that personnel are going to be trained in the use of those positive behavioral interventions, both upon employment or initially, and then on an annual basis. And then if there are restrictions that are placed on the rights of a person served, in 14D, number 2 was added that said that there is some monitoring of the effectiveness of these methods to reduce right restrictions. In other words, on some sort of regular basis, the organization is going to look to determine whether or not those restrictions actually are achieving the desired result. There's some data that indicates that those rights restrictions may not achieve the desired effectiveness, and so we're hoping that over time the organization will discover that the positive behavioral interventions tend to be more effective at creating change than the rights restrictions or the negatives. There were some changes in the personnel supports and services. It's essentially just a little bit of moving some stuff around and a little bit of restructuring. I'm not going to read through that. If there are particular questions that somebody had about that, we can get that to you at another time. I'm going to sort of end up by talking about how, with CARF here, our resource specialists really are the people who work with each of your organizations through Customer Connect, and that are the folks that help you when you've got questions about field categories or program types or any of those types of things, and they really are your consultant to us from CARF as you're going through the application process and the preparation process for your survey. The person who is your resource specialist that's assigned to Ohio is Nancy Bradley. You see the CARF 800 phone number, and the extension 7145 is Nancy's extension. That is a generic picture. That is not a picture of Nancy Bradley, in case you were wondering. Costs for CARF Standards Manual this year is $167. I don't think that went up from last year, and neither the intent to survey, the application fee, nor the survey fee went up from last year. So, whew, I was talking fast there at the end. So, are there any questions that I can answer at this time?
Yes. Okay, going back to under health homes, a question from Karen about the agency consents, and she's wondering whether the general agency consent for treatment that they utilize needs to be revised to do the consent for health home, or our providers, should they have a separate consent for treatment that's just developed for health home consumers?
I really am going to say that that's an individual organizational decision. It's just that those elements that we're identifying in that's in the health home needs to be included in that initial consent. So whether an organization chooses to do a separate one for the health home or just modify their organizational consent to include those elements, it's completely up to the organization.
Okay. The question from Joe, can you define what is acceptable resiliency? And that was back on a slide under the Integrated Behavioral Health Primary Care standards.
And could you say it one more time? You're breaking up quite a bit. So.
Sure. The question, there was, under Integrated Behavioral Health Primary Care, Standard 9, the program offers education that includes resilience and recovery.
Yes.
And Joe asked, can you define what is acceptable resiliency? And if you want, if you're not, I don't know if you want to answer that, or if you're not quite sure, I can ask Joe if he can type in a clarification.
Well, I mean, I think that what we're saying is that just where in the health home we were talking about, you've got to have all these different modules for education. In the integrated, we're looking for education of the person served that includes wellness activities, resilience and recovery, meaning recovery concepts and like protective factors, and trying to build the protective factors for resiliency with the person served and appropriate support. So I don't think that there's a specific amount or a particular curriculum that we're looking for here. We're looking that recovery and resiliency activities are included in that educational program that the integrated behavioral health primary care program offers.
Okay. And then a question on partial hospitalization. Says, when applicable, based on the needs of the person served, a psychiatrist is available 24/7. So Tracy asked, how do you determine if that psychiatrist is required 24/7?
It really winds up being a judgment call on the organization's part. Here's the way that those when there are things like when applicable, for instance, how those standards are typically applied is there would be a question asked about, well, tell me about the availability of the psychiatrist, and it might be that we have psychiatrists that's available X number of hours per week. And so then there might be some question about, well, what happens if a person has some needs after hours, and then that discussion would occur between the staff person and the surveyor. And if it seems reasonable and if it seems as though it has been well thought out by the program, then in the judgment of the surveyor, that would meet the when applicable. But when there seem to be a lot of problems where a person is unable to access, or you get complaints when the surveyors are talking with the person served that I never get to see the psychiatrist, well then that's probably when that might be a standard that there could be a recommendation around. So it really is going to be based on the judgment of the organization and based on what they believe is meeting the needs of the people that they're serving.
Okay, thank you. And right now, the rest of the questions are more for me to answer as it relates to ODMH and CARF. So I want to go back at the beginning, and I talked about when an organization, there's a few questions about when an organization has to get like integrated behavioral health primary care CARF accreditation versus health home accreditation and the 18-month requirement. So I'll try to do a little better job explaining it. When the health home rule, the ODMH health home rule, what we didn't do is put standards, a lot of standards around the provision of integrated behavioral health primary care. They're actually in another rule, and I think 2502, it makes a reference that we're really not passing those, and what providers need to do is is either obtain accreditation for integrated behavioral health primary care the next time they're eligible, and that's based upon, in this case, that's based upon CARF. So if an organization, if you've been providing integrated behavioral health for the past year, and even if you then come on board with Health Home October 1st, and CARF comes out in November as part of your routine survey, because you've been providing it for more than 6 months, we would expect you to be CARF accredited for integrated behavioral health primary care. If you're just starting it October 1st for the first time, in accordance with the CARF requirements, you're not going to meet that 6-month provision of service, so you would add it, you get a 3-year accreditation, CARF next comes back out in 2016. So that's when we would expect to see that for organizations. We do not, whether it's health home service or whether when organizations are adding any new service that requires accreditation, we do not, as a general rule, we do not require an organization to pay for a supplemental survey. We somehow take care of that in-house here at ODMH. Now, there was another slide. Let me get that slide back up there. Okay. Now, at the time, and that is actually just meets the requirements for the integrated care portion of health home service. Health home is not currently a service under deemed status. We talked about, and I don't have that rule in front of me, adding that in the future, A, to give organizations time to implement this, B, it's a new service for ODMH, and so we wanted to make sure that we can do everything that makes CMS, the Center for Medicare and Medicaid Services, who approves our state plan amendment, that everything is meeting what their needs are. And 3, because we wanted to go, not all accrediting bodies had health home standards. As I mentioned before, CARF, as you're learning, CARFs are just coming on board now. We knew they were working on it. So that's also why there's no mention of it. Now, in that 33F, that rule that's in front of you, so F1A is what we just talked about it within getting that CARF accreditation. However, if an agency chooses to obtain CARF, if you prefer to do health home, and we've had some organizations contact us and say, we want to get CARF accredited for health home. That's their preference, and you can do that, and you don't have to get CARF accredited for both health home and integrated behavioral health primary care. So that's an organization choice. So at this point, there is no requirement under ODMH rules, under accreditation, for an organization to obtain CARF health home accreditation. The only requirement is the integrated care, but we will recognize health home as meeting both the integrated care component of our standards as well as, obviously, it goes further and meets the rest of the standards. So hopefully that was helpful to explain that question. And I've got another question came in back on the intensive outpatient treatment standards for CARF, where if it's for adults, that it's 9 hours a week, and there was a change if it's 6 hours a week. So the question was, because here in Ohio we have Medicaid limits on our services, but the IOP service is not one of the services that's crosswalked to a Department of Mental Health service. It's actually seen as a separate program. So if an organization is providing that as a mental health program, then or if it's planning to do that, probably give me a call and we should talk about it. If it's an IOP program on the AOD side, that's not an issue. It's not an issue, and obviously as part of the consolidation, we'll be issuing future guidance as we consolidate, the certification and the services. But that's not going to be happening for July 1st. We're looking on as close as possible. It's just consolidating sort of the process of certification, but the services that will come later. So hopefully that hopefully those explanations are acceptable. If not, certainly feel free to contact me. Again, I want to just briefly mention for the continuing education, people needed to meet the attendance requirements. If somebody only stayed on for 1 hour, or if you joined 1 hour late, then you wouldn't meet the requirement to get the 2 hours of continuing education, and we can't do partial credit for this. But please either, if you need to send in a training report, do that. If you're a psychologist, there's a separate training report. Everybody should have received them. A few people, about 8 people, registered sometime today after 12:30. So so I did not have the opportunity to email them the PowerPoint, but I will do that sometime later today or tomorrow if people need that. And then submit your continuing education documentation to Debbie Swank. And that is all on the PowerPoint presentation that was emailed out in advance. If you don't receive an evaluation from us within the next week, then it means, according to our records, you were not eligible to receive continuing education credit. And we are asking that the training reports, they can be scanned, they can be faxed, or the mail, that you send those within 48 hours. As I mentioned, this is sort of our test to see if this works for organizations to be a little more flexible and help the learning at your end, because I know people like to, from the same organization, sit together and maybe talk about what they've heard. So that covers all of the questions that came in. I want to, as we mentioned earlier, we will follow up on that one regarding co-location and the CARF accreditation. Somebody thought since Health Home, CARF accreditation for Health Home wasn't a requirement, maybe we didn't need to follow up, but we do know organizations do want to pursue Health Home accreditation, even voluntarily, so we want to respect that. Other than that, I want to thank Mike for your presentation today, and I guess welcome you to Ohio through the virtual world. But we always appreciate, CARF has done a really outstanding job over the years of providing, I think, supporting the Ohio providers and obtaining and maintaining the accreditation on that. So we really appreciate that.
Well, thanks. It's my pleasure to be here.
All right. So on that note, I am going to thank everybody, and I'm going to go ahead and end this webinar. So I hope everybody has a great rest of the day. Take care.